Rhinitis is a highly prevalent problem that significantly impairs quality of life, yet it is often underdiagnosed or misdiagnosed in primary care. Described simply as inflammation of the nasal mucosa, rhinitis presents when at least two of the following symptoms persist for more than 1 hour per day on most days: runny nose, rhinorrhea, blocked or stuffy nose, congestion, sneezing, itchy nose, itchy throat, or itchy eyes. There are 3 widely accepted rhinitis subgroups. Allergic rhinitis results from an immune-mediated response to aeroallergens, pollens, house dust mite, animal dander, or mold, often beginning in childhood and peaking in adolescence. Non-allergic, non-infectious rhinitis arises from irritants such as certain medications, like aspirin or non-steroidal anti-inflammatory drugs, food ingredients, such as spices, sulfites, and salicylates. Hormonal changes, including premenstrual, oral contraceptive, hormone replacement therapy. Chemicals, like perfume, hairspray, cleaning agents, or environmental factors such as air pollutants and tobacco smoke. Infectious rhinitis is most frequently viral in origin and generally self-limiting. Mixed rhinitis, in which features of allergic rhinitis and non-allergic rhinitis coexist, is also common, especially in adults. Allergic rhinitis is more frequent than non-allergic rhinitis. At least 50% of patients have persistent symptoms and 40 to 60% have moderate to severe allergic rhinitis. A thorough history should explore symptom onset, duration, frequency, and suspected triggers, including family history of atopic conditions, comorbid asthma or atopic dermatitis, and inquiry after which remedies have been tried so far. ARIA, allergic rhinitis and its impact on asthma, classifies allergic rhinitis by duration and severity. Intermittent allergic rhinitis occurs fewer than 4 days per week or fewer than 4 consecutive weeks. Persistent allergic rhinitis exceeds both thresholds. Severity is mild when sleep, work, school, and daily activities remain unaffected with no troublesome symptoms. If any of those facets are impaired, disturbed sleep, reduced productivity, or bothersome symptoms, the classification is moderate to severe. Use of a visual analog scale, ranging from 0, not bothersome, to 10, extremely bothersome, helps quantify symptom burden. A score of 5 or more indicates moderate to severe disease. On examination, look for pale, swollen inferior turbinates, clear sticky mucus, and signs such as mouth breathing, frequent sniffing, and throat clearing. Allergic shiners, infraorbital skin folds, and a transverse nasal crease from the allergic salute are typical in children. Exclude other causes of obstruction, significant septal deviation, nasal polyps, or, in children, foreign bodies presenting with unilateral malodorous discharge. Certain red flags warrant immediate referral. Persistent unilateral obstruction, blood-stained or malodorous discharge, persistent facial or sinus pain, recurrent epistaxis, nasal polyps, or anosmia, usually a symptom of chronic sinusitis. These signs require an otolaryngologist or allergist assessment. When allergic rhinitis is suspected, a therapeutic trial with a non-sedating H1 antihistamine and/or a nasal glucocorticoid, or a fixed combination nasal corticosteroid and nasal antihistamine in moderate to severe cases, often confirms the diagnosis if these medications are taken regularly and sprays are used correctly. If there is diagnostic uncertainty or poor treatment response, confirmatory testing includes serum allergen-specific IgE or skin prick testing. Serum testing is widely available in primary care, does not require trained technicians, and allows continuation of antihistamines. Skin prick testing offers immediate results, but requires trained staff and is seldom provided in general practice. Both tests are particularly relevant when considering allergen immunotherapy. Local allergic rhinitis, characterized by typical symptoms and good treatment response despite negative systemic IgE testing, highlights the need for clinical judgment. Negative tests do not always rule out allergic rhinitis. Radiographic imaging has no role in routine AR diagnosis and is not recommended. Symptoms less suggestive of allergic rhinitis include unilateral complaints, discolored or thickened secretions, persistent facial pain, posterior nasal drip with thick mucus, isolated rhinorrhea, or snoring and sleep apnea. If these predominate, suspect non-allergic rhinitis or alternative diagnoses. Diagnosis allows patients with allergic rhinitis to receive pharmacotherapies, while those with non-allergic rhinitis benefit from trigger avoidance, saline rinses, or topical anticholinergics. Early recognition reduces unnecessary antibiotic use, alleviates economic burden, and improves patients' quality of life. Now, time to solve a short quiz to reinforce your learning. A set of selected IPCRG resources will be available for you at the end of this breath.